Berta. The recording is in progress and it will be available after the event. I'm so pleased to welcome you all here today. My name is Lisa Henry and I am the Secretary General of IRCT, the global movement of 160 torture rehabilitation centers from around the globe, in fact, from 75 countries, helping over 60,000 torture survivors each year on their journey to rehabilitation, helping them with their healing and with their walk on the pathway to justice. So it's all about healing and justice for us. In order to do that, of course, the need for psychiatrists, psychoanalysts, social workers, psychiatrists, etc. The list is long, the need is there. And these are the folks who are on the front lines. And therefore, a webinar like we have today, Care for Caregivers. So the caregivers are obviously in the rehabilitation centers on the front line, but the support also needs to be there for them when they've been working hours and days and weeks and months in situations like we have unfolding before our eyes these days, with the war in Ukraine, the situation in Iran, the situation in Ethiopia, the situation, the list goes on. So we're very pleased today to welcome you to this webinar, an hour and a half's time, to hear voices from Georgia, Germany, Norway, the Philippines, and Bangladesh to guide you, to provide evidence, support, inputs on what works in this particular context, what's challenging. And our hope is that you will both feel the solidarity on a call like this, know that you're part of a global movement, and be able to go home, return to work a little bit more rejuvenated and potentially with an idea of new methods that could be used in your torture rehabilitation work and in your work with survivors moving forward. So with those words of introduction, I'm going to hand it over to Carmen, who is going to be our facilitator for the day. Carmen's working at the IRCT Secretariat. So welcome everyone, and over to you, Carmen.
Thank you, Lisa. After this great introduction, I won't spare many words. I'm going to be moderating today, and I think we can go straight to the icebreaker poll that my colleague Berta has prepared for us before we give the floor to Lela Tsiskarishvili, Executive Director of GCRT. So, Berta, you can make that fantastic survey pop up.
Yes, I'm just seeing that the polling is somehow inactive, and I don't know why.
Okay.
I think because someone is logging in from IRCT host,
Mm-hmm.
but we can do it like that. We can actually pose the question openly. The question was, how stressed did you feel last week?
Mm-hmm.
And from 1 to 5, 1 being not stressed and 5 being very stressed, maybe people can put on the chat.
Okay, fantastic. Yeah. So you've heard my colleague Berta. So we have that question of from 0 to 5, you said, because we have 10 on the screen, but I think you said 5. How stressed did you feel this last week? Yeah, and we have a lot of 3s and 4s. A lot of 4s. Yeah. Good. This is a good way to get us to start thinking about.
Where do you put the 1 to 5? I don't see it.
In the chat.
Mm-hmm. In the chat.
Yeah.
Okay.
If anyone needs assistance with the chat, they can reach out to my colleague Berta, and she can facilitate support. Okay, so a lot of 4s and 5s as well. So we can do some final reflections at the end of the meeting of this webinar to see how we can connect how we have been feeling and the messages that we will be hearing from the audience. So we can give the floor to Lela now, the IRCT president, who also works in the member center in Georgia. Lela.
Thank you, Carmen. I hope you won't have a 6 after my presentation. I have prepared a PowerPoint for you because I'm laying out some concepts, and I think it's important that we see them visually, or at least it will be convenient to see them visually. And if I go too fast, please interrupt me. If I go too fast for interpretation, I might start going fast if I get carried away. So please, Carmen, slow me down, okay? Now I have to share my slides. And I don't seem to be able to share them. Share screen, advance, okay. Okay, it's not, I'm not able to share, so I'll just go without sharing, and I'll just
You're not able, okay.
Somehow not. Yeah, so I'll be talking about addressing burnout and vicarious trauma in organizations that work with torture survivors, and how we move towards vicarious trauma informed organizations, and what are the steps that we together can take, or we can take within our organizations. Because work-related trauma affects all of us in a myriad of ways. And we just did this short survey, and there was a lot of 4s and 5s, as Carmen mentioned. So there are various ways how we label our work-related trauma. It can be vicarious trauma, compassion fatigue, secondary traumatic stress, indirect trauma, empathetic strain, and emotional burnout. And you probably are all aware that in the ICD-11, which is WHO's International Classification of Diseases 11th edition, which will be out very soon, burnout has been recognized as a syndrome, and it is conceptualized as resulting from chronic workplace stress that has not been successfully managed. It is characterized by 3 dimensions: feeling of energy depletion or exhaustion, increased mental distance from one's job or feeling of negativism or cynicism related to one's job, and reduced professional efficacy. So this is officially a syndrome, and this is official. Apart from burnout, something that we as clinicians are more intimately aware of is vicarious trauma, which is the result of the cumulative effect of the traumatic material that we deal with, this material is basically inevitable part of working. Vicarious trauma is often inevitable part of working in our field because trauma is contagious.
Sorry, can you slow down a bit, please?
Okay, yes, sorry.
And we cannot see the PowerPoint.
I know, because I have not been able to share it, so I'm just talking.
Okay,
said that it's better to...
please slow down.
Okay, okay.
Lela, if you want to, I can make you host. You are co-host, but I can make you co-host.
It's okay, I guess.
Or just send it to me.
Yeah. Okay. So when we talk about vicarious trauma, many of us have been, who are in the field, have come to the field because of prior traumatic experiences. You are all aware of the concept of the wounded healer. So we all come with our background. We serve and work with people who are severely traumatized. So this creates a field where there is a high risk of professionals being traumatized. And vicarious traumatization can have effects on a personal level, which can be physical symptoms, emotional symptoms, behavioral, spiritual, as in loss of purpose, loss of meaning, questioning the good and the bad in this world, cognitive dimension, and relational dimension, which is maybe decreased interest towards the loved one, self-isolation, etc. And the higher the work-related burnout, the more evident the symptoms become. And this also affects our professional performance. Our performance level is decreased, morale in staff may go down, or our morale while doing our work. We might be detached, withdrawn from co-workers, worsened communication, conflict at work, and also behavioral ways that we manifest, being late to work, being slower at doing your duties at work, exhaustion, irresponsibility, poor follow-up. So these are the things that are side effects of burnout and vicarious trauma. So I have the slide for you with prevalence of vicarious trauma among workers who work with various victim services. However, this is not from necessarily trauma therapy field, but different fields that work with victims. So I'll read this data now. 50% experience traumatic stress symptoms in the severe range. People who do not themselves experience trauma but attempt to traumatize people. 50% experience high to very high levels of compassion fatigue. 34% met PTSD diagnostic criteria from secondary exposure to trauma, and 37% experienced clinical levels of emotional distress. Christian Prost, our dear colleague, many years ago, not so many years, but some years ago, did a study among torture treatment centers, and there about 31% of individuals had their own, of people he interviewed had their own trauma histories and very severely affected by the histories that material they were working with. And there are various risk factors, personal and professional, that may contribute to the development of formation of vicarious trauma and burnout. Among them, pre-existing trauma history, young age is a big risk factor, young age without proper supervision at work, mismatch between organization and the individual who works in the office, the lack of professional support system, inadequate orientation and training for the role. However, and this is a relatively new field of studies, while working with torture survivors and while working in general in trauma field, we, because we are meaning-making creatures, we tend to develop what is called vicarious resilience. So it involves the process of learning about overcoming adversity from the trauma survivor and the resulting positive transformation and empowerment through their empathy and interaction with them. So the impact of vicarious resilience can be having a greater perspective and appreciation of your own problems, being more optimistic and having wise hope rather than egoic hope, motivation, feeling re-energized, increased sense of understanding and belief in the possibility of recovering, and kind of a profound sense of commitment to the work that we are all here doing. So if we acknowledge the positive, may not be the right word, but the transformative side of the work that we're engaged in, we can talk about compassion satisfaction and vicarious transformation, which makes us more mature, more grown up and wiser in the work that we do. And I think what is an important discussion point for us as a collective is how we move towards becoming vicarious trauma-informed organizations, because we all are trauma-informed organizations, but acknowledging that vicarious trauma is a part of our working experience, and the experience of others' trauma is an occupational challenge for our field, and that working with victims of violence has shown to change our worldview, and it puts us as individuals and also our organizations at risk for a range of negative consequences. So a vicarious trauma-informed organization recognizes these challenges and assumes the responsibility for proactively addressing the impact of vicarious trauma through policies, procedures, practices, and programs. So it's a responsibility of an organization to allow and create space for staff to feel safe, feel heard, feel empowered in the work that they do. Because when organizations don't address vicarious trauma, we have low productivity, which I talked about, low level of cohesion, communication, poor organizational health, and we have high staff turnover. And key aspects of a healthy vicarious trauma-informed organization, and this is also based on a body of research, is leadership and mission, effective leadership, clarity and alignment with mission. Also communication style, horizontal or vertical within the organization. Management and supervision, clear, respectful, quality and inclusive of vicarious trauma. And we're going to have much more on supervision afterwards. Employee empowerment and work environment to promote peer support, team effectiveness, ongoing professional development so that people permanently feel that they're being cared for and their professional development is a part of their everyday work. And staff health and wellness is also a key aspect to a healthy organization. I had some very nice photos of Nora, Balke, and Christian Prost in my PowerPoint, which I cannot share with you because I cannot share PowerPoint, but for us at GCRT, they have been instrumental in developing some of the key practices and policies of caring for ourselves. And also there's a body of evidence, and I think I don't have time to go into it now. What are the structure in organizations with high stress and conflict versus the structure of organizations in with low stress and conflict? And we really can see the difference. Failure to maintain boundaries, over identification with clients, lack of professional distance, lack of therapeutic strategic concept, diffusion of roles and competencies, endless changing, like hectic, uncoordinated interventions. These cause stress and conflict level. Whereas on the other hand, research shows that good leadership, delegation, clear definition of roles, so on and so forth, maintenance of boundaries, care for caregivers program, coaching for leaders, which is essential because leaders also need to be assisted and accompanied in their leadership roles. This supports organizations with low stress and conflict level. This is pretty much what I wanted to share. And I think it is of vital importance that we focus on these issues, that we properly attend to these issues, because the work that we are doing is extremely difficult, very challenging. We are very often very intimately relating to the dark side of humanity. And sometimes we need reminded that we are the warriors of the, for justice, and we need support. We cannot do this alone. There's an African proverb: if you want to go fast, go alone. If you want to go far, go together. So that's why we need each other. We need professional support in order to go far and together, because our struggle is far from over. Thank you.
Thank you so much, Lela. That's a beautiful proverb and food for thought to end your presentation. And it really gives perspective when you hear the importance of having policies and procedures in place when you take into account the amount of people experiencing PTSD from secondary exposure to trauma, like you said. And now we're going to give the floor to Sheuli Barua, Assistant Clinical Psychologist at MSF, Bangladesh. So Sheuli, the floor is yours. I think you're muted. If you could please unmute your microphone, we can see you well. That's it.
Thank you so much, everyone. This is Sheuli Barua. I am working with MSF. It's Doctor Without Borders. Actually, I am one of 4 psychologists supporting the national staff and volunteers in Bangladesh. I also provide online support to our volunteers for the Malaysia project. MSF general objective is
I think Sheuli has frozen, so we're going to give a couple of minutes, if that is okay.
And maybe we can ask her to
mental health
maybe
and
close her camera so
well-being and decrease the
Sheuli,
risks of burnout. Actually, our
Sheuli?
target population is the MSF Bangladeshi nationals. Yes.
Sorry,
Can you
Sheuli.
hear me?
Yes, we can hear you. However, you froze. We're going to ask you to please turn your camera off to see if that helps the connection. Thank you. And please continue.
Yes. I'm so sorry. Hello.
No worries. It's not your fault. Yeah, and we can hear you well.
Yes, thank you so much. Actually, our target population is the MSF Bangladeshi national staff and Rohingya volunteers. Actually, currently we are supporting 1,545 employees across MSF Cox's Bazar project and Dhaka. We are providing 3 types of supports like face-to-face counseling, online counseling, and group session and training. Now, I would like to share some working experiences with all of you. The work that I do is a part of the Southeast Asia, East Asia, and Pacific Psychosocial Unit which was established to improve the mental health and well-being of MSF staff, with the focus on support to MSF locally hired staff. The unit's model of care consists of engaging local mental health service providers to individual counseling and mental health sensitization sessions to the staff as a part of MSF staff health policy. In this way, we try to address the diversity of culture, language, and the need of proximity of support. Here in Bangladesh, there are 4 of us. Now I am doing face-to-face counseling, online counseling, training, group sessions, and other 3 psychologists only doing online counseling. Doing this activity, actually we are faced some challenges when we start our journey March 2021. The challenge encountered, the first is the
Sheuli, we are losing you.
Here, yes.
Sheuli, we lost
Hello?
you for the last 5 seconds. So if you could please repeat what you just said. Thank you. Hello? Can you hear us? Sheuli is having connection issues, which is something that happens often because we're many people from very different parts of the world with different internet connection issues that we experience as well in Denmark sometimes. So Sheuli, I don't know if you're still with us. Maybe if your microphone doesn't work, but if you can hear us, could you please type on the chat to let us know that you're still with us? And we can give her perhaps a minute. And if she's not able to reconnect at the moment, perhaps we can move on to the next.
Yes.
Oh, you're back.
Do you hear me
Yes.
now?
We hear you now.
Hello?
Yes. Hello, we can hear you. Yes?
Hello?
Are you? Hello, we can hear you.
Yes. I'm so sorry. Network problem, internet problem.
Not
And we start
to
our
worry. Yes, so if you want to pick up from where you left, we're here very ready for you.
Yes. Actually, we start our journey 2021 when and that time we are doing face-to-face counseling, online counseling, and mental health sensitization session. And we are facing some challenges like is a stigma. Not many people understood what counseling support was or when would be a good time to see someone. And while some staff was struggling with mental health issues, they are not accessing the service. The second challenge we faced is a trust issue. When accessing online service, not everyone is comfortable taking to someone over phone or through the online platform. With individual session, mental health sensitization session, open discussion with the staff to identify their problems and their needs across different departments, we concluded that the main concerns for staff were communication issues, psychosomatic complaint, dysfunctional coping mechanism, burnout, depression, anxiety, relationship conflict, trauma, work-related conflict, etc. Now, I would like to share with all of you some experience with individual come from individual counseling. Here, each person can have up to 10 sessions, but if they needed more session, we can also provide. In individual session, we practice cognitive behavior therapy, person-centered therapy, and dialectical behavior therapy. Most people here understand cognitive behavior therapy. I would like to share some therapeutic techniques which work most of our staff, and I use to prevent staff stress and burnout. Uh, we usually used relaxation techniques such as breathing relaxation, mindfulness, meditation, which they can practice in any situation to relax them. The feedback we received so far is that it enhances their quality of life, relax immediately, helps to deal with their anger, etc. Do you hear me?
We are hearing you
Yeah.
very well, Sheuli. Yeah, we're hearing you excellently.
Thank you. Uh, we discussed self-care practice. They practice some distraction techniques when they feel so stressed, when their productivity level, if level is down, they use some distraction practices like hearing music, talking with others like colleagues, working for 5 minutes, having fun with others, which helps them to reduce their stress. And by practicing these distraction techniques, they find a space for themselves. It increases their individual productivity and performance. uh, uh, they also practice some thought challenge. It helps them to restructure their dysfunctional thought pattern and practice functional one, which reduce stress and burnout and improve relationship with colleagues, family, and other persons. They also used overtime techniques, which helps to focus their important areas of life that were previously consumed with worries. It also helps to be more present and engaged with other areas of life. We also some practice progressive muscular relaxation technique, doing sleep hygienic sessions to improve their sleep, giving psychoeducation, goal settings, assertiveness practice, practice pleasure and mastery activity, and time management. All those therapeutic techniques helps our staff to reduce their stress and makes them more energetic and make their productivity level well. Uh, we also uh, plan for them some trainings like stress management training, some short session like self-care session, anger management session, communication skill sessions, discussion sessions, ventilation or sharing sessions, sleep hygienic session. Uh, now I would like to share one case what I see the last year. It was very interesting and very challenging case for me. Now I am sharing with all of you. My client was 43 years old. She is working as a employee, as a national staff in MSF Cox's Bazar project. She discovered she divorced her husband because he has an addiction problem, and he always try to hurt her and try to control her uh, financially. She has a 15 years old son. After the divorce, he decided to live with his father, and she has also a 6 years old daughter who stayed with my client after the divorce. But unfortunately, her daughter passed away in front of my client. He had a road accident. Within 1 month, actually, he also lost her mother, and it was very difficult for her, and she can't accept her mother and daughter's loss. And grieving the loss of her daughter mean that it was hard for her to see someone like her girl at work. And going home was very, very difficult for her, and she always cried and being emotional at when she is working in our organization. After that, she decided to take mental health counseling, and then she go to our mental health department. Our mental health department referred her to me, and with the complaint of sleep disturbance, anxiety like palpitation, shortness of breath, bad dream, flashback, loss of appetite, lack of self-care, extreme sadness, severe emotional distress, self-blaming, trouble in concentrating, and social withdrawal. After the assessment, we found two mental health issues like PTSD, post-traumatic stress disorder, and depression. And after the assessment and formulation, uh, we are make a treatment plan for her. For emotional distress, we plan for space for ventilation with empathy and active listening, and showing unconditional acceptance to her. And for lack of self-care and low mood, we plan for self-care session, self-care, and pleasure and mastery activity. And for the anxiety symptoms like palpitation, shortness of breath, and other and concentration problems, we plan for relaxation technique, relaxation practice like breathing relaxation and cognitive triangle. And to reduce her negative automatic thought about her, she has some self-blaming thinking, and for that we plan thought challenge. And she has extreme sleep disturbance, she can't sleep, that's why we make a plan for her sleep hygiene. uh, she need 13 sessions to come up in functional life. uh, uh, we found some good prognosis after applying those therapeutic techniques like ventilation session help her to reduce her emotional distress, and it also help to improve her mood. And breathing relaxation can help to reduce her anxiety symptoms like palpitation, shortness of breath, and it also improve her concentrations. By practicing sleep hygiene, it improve her quality of sleep. Uh, um, and she also try to care herself and doing pleasure and mastery activity, and it help to improve their daily activity quality of life. After that, when she is stable, uh, then we work with her. We working with the cognitive triangle for understanding the effect of dysfunctional thought on emotion, physical change, and behavior. And we apply thought challenge, which reduce her negative automatic thought and self-blaming thinking. Thank you so much. This is from hello.
Yes, Sheuli, we can hear you
Yes,
very well.
yes.
Yes.
This is from my side. If you have any question, you can ask me. And yeah.
Thank you, Sheuli. We could actually hear that excellently. And it was, I think, a very good opportunity for all of us to understand a little bit more of a real case scenario. So I think bringing this case was a very good idea. And it looks like you were able to provide a very holistic approach, because you were talking about mental health, but you were talking as well about the physical symptoms, the heart palpitations, and all you did to address that. We have a Q&A, a question and answer session at the end at 4:05 Denmark time. So we will continue now, and people can ask questions at the end of the session. And now we're going with the next speaker, Josephine Lascano, who is Executive Director of the Balai Rehabilitation Center in the Philippines. So Josephine, the floor is yours. Thank you, Sheuli.
So Carmen, in case she logged in with another name, but otherwise I cannot see her in the call. So I don't know if it's because of that or because of some internet / time zone connection. So we can move on to the next speakers if you want to.
Yeah, that's okay. And if Josephine can hear us but cannot speak, please leave a message on the chat privately to Berta or myself or to everyone. So we can, for now, move on to the next speaker, who is Dr. Mechthild Wenk-Ansohn, who is a medical doctor and psychotherapist and a trainer on clinical supervision in the international field from Germany. And with her, we have as well Nora Balke, psychological psychotherapist. So we can start. The floor is yours, Dr. Mechthild.
Okay, thank you, Carmen.
Yes, yeah, we can hear you very well.
And I think you could just put the first slide. Yeah.
There you go.
Because I would like all of us just to take a minute for a short reflection, because there are several stress layers. The stress layer working with the target group, confronted with extreme pain and injustice. We also, of course, in our field, we have the stress layer society and the political situation. But we also have the stress layer management and institution. This is what Lela already has mentioned, and where the research of Christian Prost was about, that this was a very important factor. Yeah, and we can have special dynamics in our teams, stress layer, my team. And of course, we have the stress layer personal factors, where also Sheuli already was talking about. It might be difficulties to keep professional boundaries or our own safety or personal life. So just reflect for half a minute. What gave me stress in the last 3 months? And you can also share it if you want to in the chat. Where were the main stressors? I see all 4. Yeah, it seems to be sometimes a high stress to work in such a center. Yeah. Okay. This is why there are stress layers that come together. Besides working on individual coping strategies and with some team building activities, we have to work on the structural issues in our centers to try to optimize them and to try to have more participation, that people feel well. And our experience in the Berlin Center for the Treatment of Torture Victims, it's now called Center Überleben, Survival, where Nora and I have been working a long time. We have made the experience that case supervision can be very helpful to better cope with these stressors. Next slide. And we have been doing some trainings around the world in the last years. and we have noticed, yeah, the same as in our center, in many other centers, and especially in crisis regions, no? The service providers often have attended only short trainings, but they are confronted with complex cases in difficult context situations of war and torture, and at the same time with limitations and lack of resources for intervention. So yeah, I think many of you and we also were at high risk for frustration, secondary traumatization, and burnout, just as Lela has talked to us about it. So you can take away the slides. Just take it out. So yeah, so in our experience, it was we saw that clinical supervision, that it can be a very effective support, as it is a safe space for reflection and finding solutions for professional challenges when working with traumatized clients or clients with complex psychosocial needs. And for us, it was very good that we had somebody external coming as supervisor, an experienced person in the field, but also a specially trained person who has no double role in the organization. There is no control. It's just a place to reflect together. And so, yeah, this person, this supervisor, can take an outsider perspective, and the reflection and discussion focuses on cases and on cooperation of the professionals and on burdens linked to the work. This can be individual supervision, and it can be in a group, and it can be in a team. And we thought it's really good if it's in a team, working together, and if it's at a regular, timely scale and along the work life of the professionals. And we at the Berlin Center, we were lucky to experience a certain method, which was developed by Johan Lansen and Ton Hans from Holland. And it is a trauma and culture sensitive method. And the sessions are structured in several rounds, and the supervisors explore and reflect cases on different layers and from different perspectives in order to find solutions for their challenging or burdening professional situations. Important, it's not top-down method. Yeah, it is not like a technical supervision or a teaching supervision, but it's a guided reflection and mutual consultation in the team and with the supervisor on an eye-to-eye level. And the supervisor facilitates in a supportive and very participatory way, and yeah, works with the problem-solving potentials of the team members. You can put on the next slide.
I'm going to share again. I'm going to share
again. And the last one, the third one. Yeah.
Hold on.
So what we found that this type of supervision is for working on the cases, but it's also for the professional growth, the third one, of the caregivers, and it yeah, it helps a lot to prevent burnout and secondary traumatization and compassion fatigue, to see the risks, you know, because we sometimes are over-identified with our clients. So this helped a lot, and we think that external supervision, if possible, should be part of a policy for staff care. And yeah, that's why we have started to teach the method, and Nora will go on and talk a little bit about our trainings. Can take out the slide.
Thank you, Mechthild. And we have Nora looking forward to hear this second part from you. That was a very interesting framework. Thank you.
Okay. Do you hear me?
We hear you very well, and we see you as well.
And you can also see me.
We can see you, we can hear you, yeah.
Okay. Thank you very much for this nice invitation for Mechthild and me. And just let me say, my name is Nora Balke, and I'm a psychologist and supervisor, and I've been working with Mechthild for a long time. For me, it was around 18 years in the Center for Torture Victims in Berlin, where we started to offer a training for supervision. We started in Berlin, and we offered this training with the methods already was mentioned by Mechthild, a method from Ton Hans and Johan Lansen. And when we started, we were very lucky that Ton Hans and Johan Lansen could join us. Meanwhile, Johan Lansen has passed away. He was not so very young, but Ton Hans still is active and writing some books or articles. We started our training for clinical supervision, and we wanted to provide counselors, psychologists, social workers, psychiatrists who work with people with mental disease and torture victims, or in the social field, with kindergarten or schools, with children who suffer from mental diseases. Our trainings lasted in Berlin 31 days in blocks. We always worked on the weekend, so the participants did not have to go in holidays for the training. We taught them case intervention, we taught them contracting, we taught them teaching, team supervision, a little bit about organizational issues, and methods, various methods, not only the structured method, but also systemic approach and other approaches doing supervision. And the first country we've been with another colleague, Katharina Larondel, was in Georgia. That's where we met Lela. Hi, Lela. We did our first training there, but we improved very much in the next trainings. We did with Katharina and Mechthild in Ukraine, in the Kurdish part of Iraq, in Egypt, in Turkey with Syrians right now. And each country had his own problems, of course. And so we modified our trainings in all the countries. In some countries, we did a very short training, only intervention, although we think, Mechthild and me, that supervision is the best option. Some trainings lasted about 20 days, some of them about 35 days. But what we found out, and which was very interesting for us, we did not know that at the beginning, is that the people working in these countries also need a little bit of training in self-awareness. So one part of our trainings is self-awareness, and the other parts, as I already mentioned, are about contracting, about what is supervision, ethics of supervisions. As Mechthild already told you, we do not provide a top-down method or supervision. We try to enhance the team to find their own strength. Yeah, what else could I tell you? I think we are running out of time.
Nora, you have a little
Yes.
bit more time than we initially thought, as we have one speaker that couldn't come. So
Okay.
we still have to reserve time for the Q&A, but if you want to speak a little bit longer, that's possible today.
I think it would be easier for me, as my English is not very perfect. It would be easier for me if we have more time for the questions. And we could answer the questions then, what you are interested in, how to know about these trainings.
That is a very good idea. We can definitely do that. Yes.
Okay.
I just wanted to add something, yeah, because we would very much like to do a supervision training for member centers of IRCT. Now, we have always been in IRCT, and I've been a long time in the council, and I think it would be just great if we can make such a training with people from the centers. Yeah. So we are sort of advertising, but it's true. I mean, it's not just advertising, it's because we think it's a very good opportunity.
And it's useful.
Yeah.
Thank you so much. That's a note taken, and I think we can continue to discuss people's reflections about it in the Q&A session at the end as well. But Nora, I don't know if you want to continue with your presentation right now.
No, I think if I lost something or forgot something, perhaps you will have some questions and I will answer.
Okay, fantastic. So in that
Thank you
case,
so much.
No, thank you, Nora. Thank you so much. And it was interesting to hear what you said about the method that is not top down. It resonates with what Lela was saying at the very beginning, that the actual structure in the organization can correlate with the levels of how people experience stress and burnout and so on. So that's a very interesting point for us to reflect on. And unless my colleague Berta tells me that we have Josephine in the call, which I don't think is the case,
yes,
then that means that we should go on the Q&A. Is there any survey that we might have, any new icebreaker, Berta?
Yes, well,
yes?
we have both the poll, the icebreaker, but that we did at the beginning. I don't know if you want to have it. Otherwise, I do have the 3 questions on the Mentimeter. Well,
Fantastic.
No, it's a Padlet. So whichever you want, Carmen.
I think let's go with the Mentimeter one, since the other one, Thank you so much.
So it's actually a Padlet, and I'm gonna share the link in the chat, and you should be able to click on it and to share your thoughts about the question you'll find. Let me know if that works.
No.
It doesn't work?
But that's open questions. We have to write answers. I see the question, but are these open questions?
Yeah, these are open questions, and you have a plus arrow on the down right part of the Padlet where you can add a post. Or I will try to do it.
And it's a minimum of 1,000 words.
Yes. I can see a lot of people is writing now. 5 people. And I did post a trial. Can you do that? Is it working, Lela? Yeah. So this is an open question. The question is, what are some care for caregivers practices that you have in your organization? And again, you should be able to share your post by clicking on the plus arrow on the down right.
On the cross, it looks like a
cross,
or a plus, same thing.
A plus cross.
Yeah, the red circle, right hand corner. Okay.
And Mary, I think Mary's raising her hand. Go ahead, Mary, you can unmute yourself.
Hello, everyone. I'm Mary from SCTV. That is African Center for Treatment and Rehabilitation of Torture Victims. I work with the social work department. SCTV has a multidisciplinary team that provides the treatment, psychological counseling, social services, and legal advice. We understand that working with the survivors of torture and violence is associated with a lot of stress, and some of the measures that SCTV has in place when it comes to caring for the caregivers, this is spearheaded by the mental health team. And in this, we do have what we call the biannual care for caregivers, and then the annual care for caregivers. During these sessions are all supervised by the mental health team and external consultants. The organization has in place referrals to external consultants, just in case someone needs to seek maybe counseling from out. We do normally work with the other external consultants, just in case someone is not willing or able or feeling comfortable sharing with the colleagues within the organization. Then the mental health unit has in place what we call the self-administered evaluation tools for burnout and stress. These are normally shared to find out to help the individuals find out whether they're experiencing burnout or stress as a result of the services that they do provide. And normally with the organizations or the different department heads normally encourages staff to share when you're not to die in silence, in case you don't want to, in case you're feeling overwhelmed, be it work related or even with your personal life, you normally the confidence ways of you coming out and seek support. Briefly, that's how the SCTV team manages this, is able to care for her staff. Thanks.
Wow, Mary, thank you so much for taking the initiative of sharing all this with us. It seems like there is a lot that the SCTV is doing in this area. And I would like to read some other answers that people have written on the Mentimeter. I remind you that my colleague Berta has put the link on the chat that gives you access to it. And the question is, what are some care for caregivers practices that you have in your organization? So we have a person who said, psychosocial support person on call for all staff at all times. Once weekly self-care yoga sessions and annual team meeting with psychosocial experts. That sounds very holistic as well, with the yoga, a little bit for the body stress there too. That's fantastic. We have Spirasi from Ireland, and they say, we have peer supervision monthly, where the therapists discuss cases and difficulties with the work. Twice a quarter, we have a clinical team supervision, which is facilitated by an external supervisor. We have regular one-on-one case management meetings and team meetings, and we encourage boundaries in terms of work times, so no working outside of work hours, and take good holidays, annual leave. That's great. It seems like a very good balance as well between having regulatory measures within the team and then having some personal time, of course. And then we have another post that says annual retreats, monthly case supervision meetings, weekly case supervision meetings, and a series of therapies opportunities, supervision opportunities, and professional development opportunities. And we have a note as well that says practically so far. So I think we're hearing from organizations that are fortunate enough to have these mechanisms in place, but that's not the case for everyone. And that's something that we would like to hear more about as well. Oh, and then I can see here in Spanish, espacio de juegos de mesa, so like board games, mindfulness, and group dynamics. That sounds really fun. Some more people are saying flexi time, monthly case conferences, retreats. So, and yoga and retreats seem to be two popular ones. Thank you so much, Berta, for putting this together. I don't know if there is anyone else that wants to make a comment or share about this. And otherwise, we can go on to the next question on Padlet and repeat this exercise. Maybe we can, yeah, Berta, yes?
Yeah, no, I was just, so we move on to the next one, right? The next question.
Yes, let me ask first, because there was a person that said they have practically no measures in place. I don't know if that person might want to share a bit of their experience, but if not, yeah, if the person wants to make any comments on the chat about what it is like, I don't know if this is something that maybe has been brought up as a subject to be addressed within the organization, but otherwise, Berta, we can go with the next question. Thank you so much.
I'll just share the link now in the chat.
Fantastic.
And also feel free to jump on mic if you cannot
Yes, of
write.
course. Yeah. Yes, let's remember that we actually have a bit more time than we envisioned, which is not what's normally the case. So anyone that wants to jump in, feel free to do so. And I can see you've written the next question in the chat, Berta. Thank you so much. What type of support of staff would you like to see in your workplace and why? So to those organizations that might not be working in contexts where you have these practices, what type of things do you think would work for your colleagues, for yourself, in terms of building resilience in the face of all the work that you do supporting survivors of traumatic experiences? And I can see some people are writing already. Or maybe you do have some practices, but maybe you would like some different ones for some reasons. So it would be great to hear more about that. I have to say we're very lucky at the IRCT to have weekly yoga. So we're one of those organizations that have a weekly yoga.
Yeah, every Tuesday morning.
Yeah, every Tuesday morning, yeah. And let's see. I can see there's a few people writing, but we're waiting to see. The question for those who cannot access the Padlet is, what type of support of staff would you like to see in your workplace and why? So it might be supervision, it might be some activities out of the workspace. Maybe you're in a country where you don't have as many holidays as you would need to relax and to support your mental health. So we want to hear about that. So there is this one that says clinical supervision. That's something that they would like to see. Structured professional development program, regular team meetings rather than irregular, and any ideas for what would be good for a team that is spread across multiple countries and only very rarely get to meet in person, because 2/3 of the of the team members are in each country? Oh, increase of salaries. I think this is something that we've not necessarily discussed today, but I think that's a very honest question, and I think you need to see your work valued in that way as well. So why not? So increase of salaries. Is there anything about stress management, even though we understand that livelihoods and lack of thereof can also be a stress factor? Of course, it can add to it. There is this other comment that says, colleagues who support each other by asking, how are you doing? This gives all the staff the opportunity to use their skills to help each other and feel good about that. And other staff feel good that their colleagues are looking out for them. Yep, I think that's very true. Very often you can get too much into work and forget that you're working with other humans who have other things going on outside of the workplace as well. And it's good to check in. And then we have another post that says regular supervision, additional educations from fields of interest. And some people add, we already have really good support, so that's good. So that's a good mix of answers for us to have a realistic understanding of what's happening. Yes, someone wants to contribute on the chat. Sorry, you're using the microphone. I don't know if that was an accident or it was planned. Is there anyone that wants to share via microphone?
I mean, I'm just wondering if we can ask, are people all able to access the link and access the actual board? Is anybody having problems with the link? Just to make sure that everybody has equal opportunity.
Oh, hello.
Hello,
Yes.
William.
Hello. Okay, thank you very much. And my question is on clinical supervision. I just wanted to know whether it is possible to conduct online clinical supervision.
Okay, thank you, William. So is this a question regarding the offer that Dr. Mechthild did about clinical supervision or supervision of staff?
Precisely, it's about the presentation that you have just talked about.
Fantastic. So Dr. Mechthild and Nora, if you would like to take this question, which I will give directed to you. Yeah.
Yes, it's possible to do it online. Of course, it's not the same. I mean, this contact between people directly and to see the facial expression and the gestics and so on, it makes a difference. No? It gets more, you can see more emotions and work on this. But it is possible online if there is no other possibility. For example, our colleagues, our Syrian colleagues often work from outside of Syria into Syria with online supervisions. And it's good if you have also from time to time or the first session some personal meeting, but if it's not possible, that's the way it is. And after some time, the trust might, you might be building trust, and then more openness can happen. So it's not our favorite thing, but it's okay. And I saw another question on supervision on these writings there. We think that it's really good to have it a mixed team with different professionals working together. Yeah, because I mean the needs of the clients are often on different layers, and also how we see the clients and what we feel when working with the clients. It might be different from different perspectives of different professions or also from voluntary people. So it's good if this comes together and if people start cooperating and learning from each other, it's really great.
Thank you so much, Mechthild.
Another question.
Yes, we have time. So William, please go ahead.
Okay, my question is with regards to diversity of groups, because currently you find that in the workplace we have members of different generations. For instance, we have the millennials mixing up with the older generation. So I'm just wondering, how would, for instance, as a counselor, I can ensure that the two groups are well integrated during supervision.
Thank you, William. This is I guess this is actually maybe a question that we can ask to all the participants in this session. And I have to add, it's a very good question, because when we discuss diversity, very often we go straight to thinking in terms of ethnicity, nationality, or gender. But I think intergenerational diversity is, of course, another topic equally relevant. So I don't know if either Mechthild or any of the other speakers would like to address this question from William.
And I would like also Nora, that if
Nora as well.
there is,
Perhaps, William, could you briefly rephrase your question for everyone to ensure that we are on the same page?
Okay, my question is with regards to intergenerational diversity among staff members. So I just wanted to know how, as a counselor, I can facilitate a mixed group of persons of diverse ages. For instance, the millennials and the older people during a supervision session, because these two groups are have diverse needs, and again, their exposure to the dynamics of the world are also totally different.
Excellent question. So who wants to take that?
I think it's a very interesting question. I think that if you have different generations in a group or in a team, you can profit from each other. So I feel this is a good thing. And if you do supervision and you have the structured method, it also will help you, because with this method, you get a deeper understanding, not only for the clients, but also for the colleagues you're working with. So I don't know if this is an answer to your question, but perhaps sometimes if you start in a team with very old and very young people, you have some kind of power, different powers between the older and the younger, but during supervision, you will profit.
Thank you, Nora. And is there anyone that wants to share any other insights or tips about how to facilitate intergenerational supervision groups?
Lela.
Yes, I think I'd want, because my organization and other organizations have been in training with Nora and her colleagues in this particular method of supervision. And the country that I come from is very hierarchical on a generational level and also on a professional level. So medical doctors are somewhere up here, like psychiatrists, psychologists, social workers, now they start to exist, but it's a very hierarchical system and culture that I come from. So I think what is unique with this supervision method that Nora and Mechthild are talking about, that it's not about you as a professor of university who has like a PhD and is an MD, but it is about the client and what you feel. And it doesn't matter who you are. When we work with complicated material, very raw pain, our helplessness, our hopelessness, our fears, our hopes, on a very deep level, we are all more or less similar, much more similar than we are in our social roles. So this model of supervision is unique because it really connects us to what the client feels, And there's very little space for ego, I don't know, Star Wars things, because it's not about who you are in your professional role necessarily, but what you feel, what your client feels, and what you feel in your professional role when you work on a very complicated case. And I think in these 3 Zoom windows, we all are all very well aware of the helplessness, the horror, the terror that we experience when working with clients. Doesn't matter how many titles we have, right? So when I went through this training, this was, I think, 8 or 9 years ago when we started. So we had a very mixed group of very senior people. I was somewhere close to junior, in the middle, close to junior. So this approach really helped us calibrate and attune to what is the best for the clients. And then from like transference, counter-transference, these dynamic in-depth processes were very subtly dealt through this process. So I think that's why this model, at least for me, and I have seen, like, we have weekly case supervision, like intellectually when someone mentors a younger professional. This is a very different approach. And I myself have tried it because I have been trained to work with this method. So I have tried it in other countries that are also similarly very hierarchical. So it puts everyone in the same space. So I think that's the unique aspect of it. And it's very, very trauma informed. So that's why it's unique.
Thank you so much, Lela. Again, great to hear as well, not only your perspective as a clinician, but also the practical experience that you've had actually seeing this session unfolding in your center. That's a great thing to bring to the table. Thank you so much. I don't know if there is any other questions or comments from anyone. Feel free to use the microphone. We have 12 minutes. We could, Lisa asked us, is it possible to hold a training for many persons at the same time, or do smaller groups work better? Lisa, I don't know if you want to explain that a bit.
I'm just trying to get an understanding. If we wanted to host a training, right? Is this training, would it be focused, and this is for Nora, among others, but is it better to focus on, one organization and their team there? Or could the supervision be, or this methodology be used for, I don't know, staff from 2 or 3 centers? Or, can you explain a little bit the manner in which it functions best, in your opinion?
Yes, I think it's good to have some more centers in one group, and but what is needed is that the centers all are working in a clinical context. Yeah, so it's not. Yeah, in Germany you can become a supervisor when your profession was like a teacher, but we want to have people who are working in the clinical field and who are experienced a little bit in the work. But of course, the more center, the better.
Thank you. Thank you, Nora. And Berta, we have a question number 3. We have 10 minutes left, so maybe we could use the question as a means to have another final discussion. Let's click on the Padlet link on the chat. And the last question is if there is any practical case of care for caregivers, good practice that you want to share with us. And so we encourage you to click on the link, have a thought, and write your answer there. Is there any practical case of care for caregivers, good practice that you want to share with us? If there is anyone that doesn't have access to the Padlet, you can also let us know on the chat, or feel free to just open your mic and the floor will be yours. Yes?
Can I open my mic? I think there's one very crucial piece that we have not properly addressed. It's the staff that is not necessarily working with clients.
Mm-hmm.
In our centers, it's not just psychotherapists or medical doctors, right? So we have program managers, advocacy office. So constellation might be different. So
yeah,
fully affected, and it might not be vicarious trauma or secondary traumatic stress, but burnout, compassion fatigue, and often we tend to leave these groups out of our professional discourses. So it is equally important to include non-clinical staff in the programs that that we develop to address burnout, compassion fatigue, empathetic strain, etc. So yeah, this is what I wanted to emphasize. And very often they have the staff that is not directly linked with client work has less education, therefore less kind of knowledge how to deal with work-related stress, and often organizations tend to leave this non-clinical staff out. So it's important that we acknowledge it and also acknowledge that there are different approaches to making them part of this process of prevention.
Thank you, Lela, for that important point. And yeah, I think that makes total sense. And especially as organizations try to include lived experience into their staff members through survivor engagement approaches, or because they realize that's the way to go. You might have someone working in an administration position, and people might be still hearing things that might expose them to memories or triggers and so on. So of course, that's a very important point as well. Thank you so much. And I'm going to check the Padlets. So we have an answer. Is there any practical case of care for caregivers good practice that you want to share with us? They say having supportive managers who are aware and understand the importance of the prevalence of vicarious trauma when working with heavy cases. Managers making room and practices to prevent vicarious trauma. So that's I assume that's something that's happening in the member center that the person is referring to as an example of good practice. And we have on the chat as well a couple of comments. It says, would this approach not work for non-clinical teams? Well, that's something that has been addressed perhaps by Lela's questions. Yep, you were picking up on that question. And then we have a comment from Kay that says, I don't know if it is called a practice, but using the check-in and check-out to start the activities is very helpful for the practitioner and beneficiaries. And this is a comment from Kay IRCT. So Kay, I don't know if you would like to explain your comment a little bit for people who might not have an understanding of the check-in and check-out activity that you mentioned. Would you like to
yes,
elaborate?
may
Yeah.
Initially, thank you for this wonderful meeting, and I'm sorry, I apologize for my late participation, but I had something I just want to explain as a practice actually that we use to the IRCT in Albania, that check-in and check-out, we started to use this technique with the refugees initially, and then with the torture survivors we're treating in the prisons or somewhere else. Actually, using the check-in and check-out, we are finding it's better to start the activities, makes the beneficiaries feels more comfortable. We do not start asking how are you today, what are you doing today, but we start drawing, singing, and starting an activity to make the klima more comfortable, even for our practitioners or psychologists, even for the beneficiaries. I don't know if it's called a practice because that's not my field, because I'm not a doctor or psychologist, but is something that we're mostly using in those days in here.
That sounds great. So is it like a kind of like a group dynamic icebreaker sort of thing? And is how often do you do that? Is it something that you do as you start your day, or weekly, or with some activities?
I think because it's good to know how they enter the day, using not using the words, because sometimes we do not speak the same language, but especially in a refugee camp, for example, with the Afghan refugees, we came from different backgrounds, different cultures. We start the activities actually, for example, when we do the group therapy with women, or some kind of music therapy. We start with a check-in to draw how you're coming today, your feelings, and to explain that or not.
Excellent. Thank you so much, Kay. I can see how that would increase the group cohesion as well, doing an activity all together. And again, like we said before, taking the time to remember that it's not just like a work buddy. It's a person with a life outside the workspace as well, with with many things happening that will impact their mental health.
Can I ask you, Kay, what are you doing as check-in and check-out for the team?
Even for the team, yes. We start the check-in. We use the check-in a technique to not make the difference between the practitioner and the beneficiaries. So we are all the same during the activities, and we use the check-in to start the day of the work in the camps especially, and the check-out to close the activity. If we are leaving more happy or we are leaving more stressed, so it depends on the day and on the activity.
Okay. Thank you so much. We have 2 minutes left, so everyone is very welcome to. Oh, there is a question from Lisa. How can IRCT support torture rehabilitation centers to make sure there is care for caregivers in your centers? What could the IRCT do to support your centers to ensure that there is care for caregivers in your centers? So is it a matter of discussions with the leaders? Is it, is it something that staff are asking for, but there's no resources, or the resources are there, but the idea is still not shared by everyone? Let's see, Erika Valtierra says, who can we contact if we're interested in the supervision training? So you can contact Nora, Mechthild, and myself. I'm going to write my email address here. So I am one of the project associates at the IRCT, and I'm doing a bit of work with some funding for Ukraine support that includes an element of care for caregivers. So you can contact me, and I don't know if Nora or Mechthild might want to leave their details on the chat as well, but otherwise feel free to use my email address. Oh, sorry, I've just realized I said thank you. Yeah, realized. Yeah, thank you, Berta. I realized I sent it privately to my colleague Berta, and Berta's now shared it. Thank you so much.
I think it is really good to have a central point of a focal point. So okay, people can contact Nora and me for questions about the training and things like this, but for showing their interest and how the planning goes, I think it would be really cool if you, Carmen, are the focal point for us.
Fantastic. Of course I am. Yeah. And Erika says, well noted. Thank you so much. I will stay in touch. Fantastic, Erika. We'll be here waiting for your queries. And I can see we have a hand up by Lisa.
Thanks, Carmen. So what I'm hearing is an awful lot of knowledge and a lot of great experience among the members, right? And different people contributing what works for them, how it's working in their center, how it's not working. And I think I heard very clearly a call, especially in the first interaction from Lela, about this is also an organizational matter, right? This is organizations, and I think leadership, understanding this is a very important part of what we do. And there needs to be, time allocated to it, there has to be management focus on it, follow-up, and resources. So I just asked that question. We often meet with members. Many times it will be with the heads of the organizations. If there's any need for messaging there, or thematic, focus, we could be doing that if the ask is there. But as I often talk with staff about, we like to respond to demand. We should be demand driven by what members need and say from the ground. So I'm seeing in the chat, William suggesting IRCT organizes a joint supervision training. We note that, and we'll see what we could potentially do about that. But any other suggestions, please, feel free, so we can hear you and try and respond to your needs.
Thank you so much, Lisa. I encourage everyone to leave their suggestions in the chat like William did, so we can collect them. And also Berta has a final evaluation poll that we kindly ask you to fill in. It's nice and easy. It's popping up on your screens now. So if you could take a minute to do that. But as I said, we're also taking your suggestions from the chat. So feel free to also post your recommendations or suggestions for us to take into account. We have Eugenia Mpande, who says that she agrees with William about the IRCT organized training. And we have some comments from Croatia, IRCT Zagreb, who says that they're very happy that the topic is recognized and openly discussed, and that they recognize the need to provide care for caregivers, because not paying attention can lead to many unwanted consequences. Yeah, and I think that resonates again with some of the things that have been discussed today. It can ultimately lead to staff turnover, and not having the support in place is something that can affect the person, but ultimately productivity as well. Yeah, and IRCT Zagreb says satisfied employees, high-level services, satisfied users. Yeah, and oh, sorry, I thought there was someone that wanted to use a microphone, but I think might have been a little accident. So, okay, how are we doing with the polls, Berta? How are you getting your answers?
Yeah, I think we can close maybe in a minute.
Super. Yeah.
Thanks to everyone.
Mm-hmm.
A lot of appreciations in the chat.
Yeah, that's right. And we have a comment from Polly Rosdale as well, saying thank you so much. I think there is sometimes a tendency to suggest that self-care is solely an individual issue. It's so valuable to understand it as your speakers. Sorry, I have an issue with the chat of your speakers. Could you help me with that, Berta?
It's an organizational issue. Yeah, it's absolutely.
Yeah. Thank you. That's what I thought it would be going, but I thought, what if actually there was an extra line that I'm missing? Fantastic. Very good. So thank you, everyone. Unless there is any closing remarks or any final comments, I think that was the session for today. Thank you so much for the participation, for your contributions. And
amazing to see you all.
Yeah, it's great to see everyone. And you have
the
contact details in the chat. Thank you so much to all.
Thank you.
Enjoy the rest of your day. Bye-bye.
Thank you so much.
Bye.
Thank you.
Thanks all. Ciao.
Bye.
Thank you.
Keep up the good work. Thank you.
Thank you, everyone. Love from Australia. Bye.
Love to you from Copenhagen. Happy Thanksgiving for those from that continent.
Thank you very much, Carmen. And thank you very much, Lisa.
You're so welcome.
Really nice to see people from the different centers, and and thank you for your good moderation and everything. Say goodbye.
Welcome. We'll talk. Ciao.
Work together, stay together to future plans. All right.
Yeah. Take care. Hi, Miriam. Hi.
Bye-bye.
And thanks
Bye.
from MS Up. Ciao.
Thank you. Ciao.
Bye. Bye.